Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's online course, Fundamental Skills for Preceptors, with information available at www.aacn.org/preceptor skills. Now, here are your hosts, AACN's Chief Clinical Officer, Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Hi, this is Vicki Good, and welcome to the Voices in Nursing podcast. I'm joined today by one of AACN's guest co-hosts, Devin Bowers, who's also our AACN's Practice Excellence Director.
Hi, everyone, AACN community. It's so great to be here. I'm really looking forward to being the guest co-host today and our conversation we're going to have.
We're excited to talk with Dr. Sylvain Trepanier, Providence Health Systems System Chief Nursing Officer. Devin and I both had an opportunity to hear Syl speak about the co-caring model at Providence a few months ago now at a conference, and we were just super excited about that and would love to share the learnings with our AACN community. Before we start, though, we would like for you, Syl, to tell us a little bit about yourself.
Well, first of all, Vicki, Devin, it's great to spend this time with you both and the AACN community today. And as you said, I serve as the system chief nurse for Providence, which is a healthcare system based in Renton, Washington. In this capacity, I support nursing services for roughly around 36,000 nurses who are practicing in seven different states. I've been a system and/or regional chief nurse since the early 2000-ish, and a CNO. I can't believe it's been like 20 years this year that I've been a chief nursing officer. I started, like all of us, at a very young age, so this is how that all happens. But I've always had a passion for leadership and for creating systems that brings joy to the practice of nurses and the entire healthcare team, for that matter, as well. Spent a lot of time doing some work in supporting new graduate nurses transitioning into practice, and now over the last 3 years, really have dove in with nurses in rethinking how we need to approach our work.
Well, Syl, thank you so much for your background. That leads us into the next question just beautifully. And we are hearing so much buzz right now around this topic, and I'm going to do air quotes. The audience can't see my air quotes, but new models of care. So tell us what that means, a new model of care, and a little bit about the co-caring model at Providence. How is that a new model of care?
Yeah. I'm going to start us off with we're kind of sort of after the dark side of COVID, if you will. We find ourselves, at least we're on the other side of that curve. It's debatable on what exactly it ended or not, if it ever will. But you know what I mean, like when, after the big crisis, and realizing that, people were leaving our professions in droves. People were leaving healthcare in droves. And I had a bit of an aha moment at that time. And I was thinking, gee, I've been at that point in time, it was like 31 years as a nurse. I've been practicing for 31 years. The entire world has changed around us. Technology has changed. How we approach life is very different. And yet, if you walk into any acute care hospital and you look at how we approach the work, how we divvy up the work, it really hasn't changed that much. And if we're being honest with each other, I can't remember any time since I've been practicing that we had enough nurses. We never had enough nurses. And we've changed all sorts of things. We've tried a lot of stuff. But here's one thing that, at least in my area of practice, that we had never really attempted to do, is change the work itself. And I'm having this conversation with nurses, and I share with them the same way I'm sharing it with you, and then I'm inviting us to think about that, and what does that mean? And is this a perfect opportunity for us to rethink about how we approach our work. Could that be the reason, the root cause of why people are leaving the practice? Because they don't like it anymore. Well, I know it's not deliberate on my part, and I've been a large contributor of creating nurses and having expectation of nurses at the bedside that have become taskmasters, going from one task to another. And if you think about how they show up every day and what we ask them to do, what they see, what the work is, they're really going from one task to the next, particularly because patients are not with us as long as they used to be, and yet they have all of these things they need to do for them. And we're still, for the most part, at least at Providence, that's the case at that time, 100% practicing in a primary care, total patient care model where we expect nurses to be all things for all patients. That's what we say in one sentence. And in another sentence, we say, and thou shalt practice the full extent of their practice. Now, that just all of a sudden to me, the aha moment was that doesn't even make sense. I can't even compute that anymore, right? So, this was literally a 2-year journey, asking nurses. This is one unit at a time, inviting nurses to be rethinking about. First, let's ask ourselves, what are the needs of our patients? These patients on this unit in this community need XYZ. Once you have clarity around those needs, let's ask ourselves, what are the activities that are required in order to meet those needs? And only then should you be asking yourself the question, and who's best positioned to serve those needs, to do these tasks? And be very, very honest on where do you need a licensed nurse? Where can others step in? And where you may still need a licensed nurse, but he or she may not necessarily need to be physically in the room to care for patients, because we know that it is safe to care for patients virtually. All of that exercise led us to what's known today as our co-caring model. I have to be fully transparent by saying, is this, nirvana? Is this utopia? It's not by any stretch of the imagination, but it's the beginning of something pretty big. And I say that because we have so many great outcomes where patients are cared for or where nurses are practicing in that environment. So it's an environment where you see nurses approaching their work as a team. This is not these are my patients. These are our patients. You have a nurse that shows up virtually, you have a nurse that shows up physically, and every single nurse at the bedside is also teamed up with a caregiver. In some cases, it's an LV and LPN, depending on what the needs of the patients are. In some cases, it's a technician, whether it's called a CNA or a PCT or a PCA or all the various acronyms that we have out there in all the various states. And they work collaboratively together. They walk into the room together. The biggest change in that model is nurses needed to relearn, and they still need to continuously learn how to delegate. They're so accustomed to do everything that they're not leveraging the entire healthcare team. And when they do that, though, there's so much beauty and great music happens because that's when everyone can leverage each other. That's when everyone can meet the various needs of our patients. And even the patients themselves are telling us where they are receiving care that way, that they're seeing that the nurses are showing up very differently. They're not running from one task to the next. And we could talk about some of the really great outcomes that we're seeing. And before I say that, I'll describe to you what I'm seeing every time I go in a unit that's fairly mature in that model. And the first thing that you recognize is the sound level is so much lower.
Interesting.
Yeah,
You don't hear the call bells anymore. You don't hear all the bells and the whistles in the room because now you have 3 pairs of eyes, both physically and virtually, constantly roaming and anticipating the needs. And that's what our patients are telling us. And because of that, all of a sudden, the noise is so much lower. We're in the process of doing some research around this. We got approved mid-year through our IRB, and we're doing a longitudinal study around this. And one of our key elements is around the stress level that we're trying to capture. My hypothesis is that as that sound level has gone much, much, much lower, I suspect that nurses are not perceiving as much stress
Hmm.
as they were in the past. Hindsight 2020, I wish we would have put some devices on them, because I think that physiologically there's probably something else happening as well, but probably a latter research for us to do.
Yeah, I was going to say that's a great next step in the research journey.
Mm-hmm.
So, I mean, you're singing my song because I've said, we've done primary care nursing for 50 plus years. My mom did it when she was a nurse. We're finally learning that maybe there's other ways to do things.
Yeah.
But I think some of the critics out there would say, "Oh, this is just another version of team nursing."
Mm-hmm.
So, how is this different? What would you say to those critics?
I would say, first of all, we're very deliberate about not approaching it from a functional perspective, because that's one of the critics that we had around team nursing. Although there's a difference between team nursing and functional nursing, some called it team, but they really were practicing functional.
Right.
So we are very deliberate about not being it in a way that this is your lane, this is my lane. It's really, truly working collaboratively together. Well, for one thing, I would say the biggest difference is back then we didn't even have any technology that allowed us to practice virtually. So now you have a team of 3. This is not a team of 2. And where they are constantly collaborating together, both virtually and physically, to figure out what are those needs and who's best positioned to meet the needs of our patients. I also the way we envisioned this for the team that shows up physically, we're encouraging people to be in the room together, to really truly be an extension of one another. And the best way you can meet all the patient's needs is by being together in the room. One, less disturbances for the patients. We're not going in and out as more frequently than we need to. But yet when we're there, boy, is it meaningful, because we can address many needs at the same time, as opposed to say somebody else will come in to address this or somebody else will come in to address that. That's how I would describe it. Are there elements that are similar? Yes, there are. And to the biggest critics out there that might say, been there, done that, I would say, well, actually, no, you did not, because you did not have any nurses who were practicing virtually at the time.
Sil, on that note, with a team of 3, so you have a
Mhm.
virtual nurse, you have a nurse at the bedside, and then you said either an LVN or a tech of some sort. Can you describe just a little bit about the function and role and the patient care that each of those individuals of the team provides?
Yes, and
So
that's
how is the role of the virtual nurse different than that of the,
yeah,
the nurse that's at the bedside?
yeah. And that's an evolution. I would say that we started, and most units start with certain, activities and collaboration, and then the list builds on as the trust develops within that team. I think that's very, very important. I also have to call out the fact that the nurses who are practicing virtually are in their home setting. They practice from home. And we did this for 2 reasons. One, we didn't want to put them into a room that all of a sudden, just because of the crisis of the day, they could be pulled out. And then on Monday, on a full moon, you practice this way. And on the Tuesday, when the moon is on Saturn, you practice differently, right? We don't want to do that to our patients. We don't want to do that to our nurses. We need to be very clear and deliberate about how they need to practice. So they work from home. Now we have a whole subset of nurses who are willing to continue to practice supporting acute care patients receiving care working from home. So that now opens up our ability to recruit people and to retain people in a much bigger way than we were in the past. And I would say that generally speaking, if you think about plan of care, activities of daily living, medication administration, treatments. That all happens by the nurses who are there physically and the technician that's there physically in the room. We have yet to develop the technology where, holographically we can actually care for patients. So until we're there, treatments, are going to happen that way. Everything else, like literally everything else, admission, education, discharge instruction, care coordination, second nurse verification, for instance, an additional pair of eyes for someone that may need assistance, whether it's for to care for the patients or just to double check them or to brainstorm about something. So all of that then tends to be managed and delivered by the nurses who are practicing virtually. And we tend to see a longer list now of things that are happening that the nurses themselves are saying, there's why are we doing this? The virtual nurse could potentially do that. They show up when we have multidisciplinary care roundings, for instance, and because they have the time to really thoroughly assess the whole situation of the patient, they actually are much better contributors to that conversation than the nurse that is there, physically. They are also able to bring in third parties into the conversation. Imagine that, Devin, God forbid something happens to your mother that is in another state, and you would really want to know what's going on. And today you would be calling on a unit. You might be, talking to a nurse or a member of the care team over the phone. You wish you'd have eyes on your mother. Well, now on those units, we can actually bring you in. You do have eyes on your mom. Your mom sees you at the same time as seeing the virtual nurse, and it's a three-way. Everybody sees each other
That's
conversation, and that has actually helped us also deliver home care instructions that may have been delayed in the past because, Devin works full time. She can't come to the hospital until 8 o'clock tonight. And by that time, it's going to be too late to discharge, your mother. Well, now if you have a 30-minute break during your day, we can figure this out, and you can have mom home by that time because she'll be all situated. So it's definitely having a lot of impact from an operational efficiencies as well.
The virtual nurse, are they employed or a member of the unit team, or are they more of a decentralized virtual nurse that they can go to any unit? Can you describe?
We have two models. It depends on all sorts of business arrangements that we have in various states and in various hospitals. So in some circumstances, it's a better business arrangement, and then to meet the demands of prior business arrangements that we may have, then we make sure that those are member of that unit. They are reporting up through that unit. And in some instances, it actually makes sense to use a centralized hub. So we do that. In fact, that is the next generation of where we're going in, where we're thinking we're going in certain states, where it really just makes sense, where we can actually better leverage the resources. And I mean, at the end of the day, we have one healthcare record for the whole healthcare system. There's multiple instances, but for the, technically speaking, the record looks pretty much the same in all of those three instances. So if you're licensed in a state where the patients are receiving their care, technically you could be part of that team and support the nurses. But once again, we want to be very mindful and deliberate in recognizing the various business arrangements that we have across the system.
So I love the outcomes that you've briefly described for your patients and how that makes them feel and the families. So how is this translated to the direct care staff that are working with the model? I know you spoke to at the beginning of the session, and I've heard you numerous times speak about bringing the joy back to nursing. So what would the team say, and how did you get them inspired to do this?
Yeah. I'm going to start with the end in mind by saying that the retention on the co-caring unit is phenomenal. So that's a really key indicator that people are happier than they were before, which was the impetus for us doing this, particularly as you and I are facing one of the largest shortage we're going to be facing by 2030. And that's oftentimes lost in translation. And I need to say this for our audience. Don't be fooled by the lowering of our turnover today, because all indications shows us that we have a pretty significant part of our population, a nursing population, that will retire, that will stop to work, and we don't have enough coming in. And those who are willing to come in are not willing to work in hospitals anymore. So hospitals are at great risk. So we have to make sure that we're not fooled. So outcome is that our retention is much higher, and in fact, even internally, our retention of nurses is greater by 2 percentage point internally within Providence on co-caring unit as compared to all other units. So that, I mean, that to me really reminds me that there is something, something going on. I'm also going to say, Vicki, that is a overtime outcome that happens. The first 3 months, 6 months, they're hard. It's a new way of thinking. It's a new way of approaching the work. To some nurses, that's not what they signed up for. They like what they like. The status quo is what pleases them. And unfortunately, in fact, I just wrote this today in a post that I put on LinkedIn, that I believe that our biggest risk in our profession right now is the status quo.
Absolutely.
We have to your point, where we have to inspire people to, sometimes reminding us of the why. I mean, it's very important, but sometimes we don't want to hear the why. So how do we get ourselves psyched up? And I think that the number one ingredient in approaching this type of work and being successful in this type of work is having a solid leadership team that's there at the bedside, that has great connection with the bedside caregivers, that they trust each other, that they both trust each other. And unless you have that at the onset, doesn't matter what you're trying to do, you're just not you're not going to get anything done, let alone a change in model of care. And the way that we are also approaching this is we're inviting nurses to talk to each other across the whole system. We've asked some of them to give us testimonials, whether they're written or recorded or video recorded. We're holding internally sessions where we have open houses on units that have matured, and we're inviting nurses to go visit. We just recently invited, I think it was over 50 nurses who traveled to Texas from various states where we practice, and invited them to go check it out yourself, ask questions, talk to the patients. We inviting them to spend time actually side by side, shadowing nurses who are practicing virtually, nurses who are practicing in this model, so they can hear it directly from them. From a change management perspective, internally within Providence right now, when we're talking to nurses about this is not Syl's story to tell. This is a nurse to nurse story to tell. It was built for nurses by nurses. I planted the seed. I invited people. I created the table. I invited people to have a imagine the world conversation. I'm inspiring them to continue to imagine the world that's very different. And that's the extent of my role as a system chief nurse. At this point in the game, it's about a nurse to nurse conversation. That's how they get inspired. And it would be disingenuous of me to say that there are some nurses who are not easily inspired by this work. We also have to figure out a way to approach them and to invite them into this conversation. As a nurse leader, if there is one thing that I had a mentor and coach one time that taught me to, particularly if I'm passionate about something, when I hear no, I actually hear not right now.
Mhm.
And it's the same thing that's happening right now. When I hear bedside caregivers who are saying no, an adamant no, because they are pleased in the status quo and they believe that the status quo is what's going to allow us to be successful, we're choosing to hear, not right now. And it's okay. It might not be their time. We have plenty of units that we can go across the organization and start the revolution.
Well, and isn't that the first sign of change management is the people have to be ready for it. So I
Hmm.
love that
Hmm.
approach. And
Hmm.
I had a mentor tell me that as well. No means not right now, not
Hmm.
necessarily no.
Hmm.
So, Devin, I think you have the
Yeah,
next
Sil, this is
question.
great. I had a question about inspiration, and you went down that pathway. I didn't even have to cue you up for that. That was great. On that spirit of inspiration, have you had any acute, progressive, or critical care units go to the co-caring model? As you know, the AACN community is primarily progressive and critical care nurses, and just curious if you've had any units, a higher acuity, do this model, and if you haven't, are you all thinking about it?
The short answer is yes. And a PCU is where we're going to start. In fact, we dabbled in it a little bit. It didn't work well for us. We did not have the right ingredient that I was describing initially, which was a stable, unified leadership team that was on that unit. So we backed away from it, but then we went back into another ministry, and where it's working really, really well in a progressive care unit. The way that the way we're approaching this is we're telling each other, we made the statement that it will be the new model of care everywhere, or a resemblance of that. Like the status quo is just not going to happen. Now, there might be some exception, and we can talk about the exception. We can identify what those exceptions are and why they should be exceptions. So it'll be the exceptions rather than the rule. I could think of a long list of patients who are even in a critical care setting today who could very well benefit from getting part of their care, or their family members getting part of the care of their loved ones virtually. I mean, right now we're just we started with the role of the nurse, and you can just imagine and get your imagination go. And there's many more disciplines that could show up virtually to care for patients. And as I say this out loud, I always caution us, though, let's not create an environment where everybody's disappeared from the bedside. The only people who we have left are the registered nurses and the tech, and now we're back to square one. We can't
Yes.
do that to ourselves. We can't do that to our patients. And at the same time, there's tons of stuff that we could do virtually and care for patients virtually. Not to mention the fact that in the critical care space, we've done this for a while now. Many of us are leveraging monitoring patients virtually. And that's a piece of us changing the model of care, if you will. We didn't call it that, but if you think about it, we're supporting the team in a way that we weren't supporting it before. And we're very deliberate at Providence in differentiating the difference between virtual nursing and remote nursing. And virtual nursing is those who practice nursing who are directly touching patients virtually or in person, right? So virtual nursing is those who are practicing nursing, but yet they are directly interacting with patients virtually. Remote nursing is they're practicing, they're not touching the patients, they're looking at stuff behind the scene, they're looking at waves, they're looking at data, and then they communicate that directly or indirectly to the care team, and the care team takes action. They don't have direct interaction with patients. Those who have direct interaction with patients, that's when we draw the line and say you're practicing virtually.
That distinction of those two roles is really helpful.
Yeah, and I think that's one thing that oftentimes our members struggle with is what are those two differentiations, and the fact that virtual nurses are still direct care nurses. They may
Hmm.
not be hands-on, but they're still directly taking
Hmm.
care of that patient.
And I could give you tons of examples. In fact, that's what I invited the nurses to do when they're talking to one another, of good catches that we have done in ways that if it wasn't for the nurse showing up virtually, um, something bad could have happened to our patients.
Yeah. So speaking of the good catches, our listeners love to hear patient stories.
Mhm.
So do you have a patient story that stood out to you using the co-caring model?
There's a few of them, and I'm going to go back to probably the very first one that I heard, where we had a nurse who showed up virtually to care for a patient, and she had visited that patient the day before. She visits the second day, and she visited at a time where she knew it was a good time to go visit because they were constant communication with the care team that was there physically, present, and saying, can you check in by such and such a time because of all the care we have to render over here. It'd be great to have eyes on this particular patient. She comes in, she looks at the patient and realizes that there's something that looks off, and zooms in, because we have really amazing camera. You can zoom in and literally look at the pupils of our patients.
Wow.
And notices that what she believes could be signs of stroke on a patient, and calls the team, does everything that they need to do, and sure enough, made an intervention that prevented the patient, from developing, perhaps a full-blown active strokes, and who knows what the symptoms may have been. You're going to tell me, well, he or she was in the hospital. Would it have really made a difference? Time is of essence. You never know in a traditional model. If you think about it, I don't care how many patients nurses care for. When you're in a primary total patient care, nurses are accountable and need to do everything for all patients. They are not, and it's impossible for them to be in the room as frequently as we would want them to be. You need somebody with good assessment skills to be able to identify when something's going wrong with the patient, and you don't need to be physically in the room to do that. You can do that for certain elements, and it was perfectly safe. It was and I'd hate to think what could have happened to the patient and how much time could have elapsed in between time. Not because the nurses at the bedside is not doing their job. It's because they're going from one priority to the next. And we've set up the systems today where we practice primary care and total patient care, where nurses are not as frequently in the room as we would want them to be, just because of the system. So we have an obligation to rethink about that.
Yeah, that's an amazing story, and lucky for that patient.
Mm-hmm.
So, one of the things that we've begun to hear from the AACN community when it's working with either a remote or a virtual nurse is about the team dynamics, collaboration, and teamwork. And AACN standards, I'm sure you're very familiar with them, the AACN standards of healthy work environment, where we talk how important true collaboration, skilled communication, effective decision making, and meaningful recognition are among teams. So, how are these units in the co-caring model developing those healthy work environment standards among the team, between the bedside team and the virtual nurse?
Yeah, I love that question, and different ways that they do that. And I'll first start by reminding us of a comment that I made earlier. One of the biggest learning curve for nurses to practice in this environment is the ability to really fully leverage and embrace their technicians, for instance, which means that they need to relearn how to delegate and how to trust and understand that delegation is part of our practice. It's completely acceptable. In fact, not doing it is not acceptable, but somehow we lost track of that. And so that goes for the whole team, right? So whether you're there virtually or whether you're there, physically, a lot of the healthy work environment that they are building for themselves, of course, has to do with the fact that they need to know each other. So we're creating the space and we're creating moments that they can connect together as a team. That is part of the reason why we want them to show up in the room together. So that it's not about, go do this and I never see you interacting with the patient, because there's a lot to be said about seeing each other, interacting with the patient, so we can coach each other and we can be better at it, for our patients. So I think that these moments where we're inviting people to show together, these moments where we're having some deliberate connecting point between all three of them, and having the ability to revisit and review the day or review events and speak to that. I think our ability to also invite nurses to talk to each other across the system is also one way of them to continue to continuously rethink on how that can evolve for them. Because we're very clear, at the end of the day, safety is our number one priority. Safety for our patients, safety for our caregivers is crucial. That's our number one priority for everybody. In an era of a nursing shortage today, and even worse tomorrow, we have to be real about ensuring safety for all via new models of care. That has to be part of the solution.
So, Sil, I think I could talk to you about this for hours because you have so much to offer and the learnings have been vast with this new model of care. But our time has to come to a close. And so, what is the one thing you would leave our listeners with today?
Remember that the status quo is our biggest risk right now. The whole world has changed around us. We have to change. Need I remind us that those who have not changed over time have had some really negative consequences. Let's not think for a second that that can't happen to us in healthcare. It's actually happening all around us. So that's also a very important, point to remember.
So true. Well, I just want to thank you for giving us the gift of your time today. We appreciate it very much, and I'm sure our listeners will have lots to learn from this, and invite them to reach out to any of their friends that work, within the Providence healthcare system to learn more because the learnings are vast. I want to remind all of our listeners that we want your feedback on this podcast as well as any future podcasts that you would like to hear. So please email us at podcasts@aacn.org for your feedback. And thanks again, Sil. We appreciate it.
You bet.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's online course, Fundamental Skills for Preceptors, with information available at www.aacn.org/preceptor skills.